For those people that may not know, we are actually live streaming right now across the Twitterverse. That's a word I just recently learned. For all those people that are joining us on the live stream, welcome to Resuscitation in Las Vegas. And also just so all of you out there in the world that are watching via live stream know, there are certain problems associated with live stream that when you see things on live stream, the speakers are actually a lot taller than you may think. And Twitter sometimes removes hair as well. So just a little caveat there. This year, for the first time at Resuscitation, we actually have sponsored 10 scholarships to residents in various places around the country. So let me just see, how many of the scholars are here? There should be 10. I thought there was more than that. All right, well, maybe they're out at the casino. We didn't actually specify they have to come to the conference, did we? So, all right, maybe that's the problem. For all of you residents and young folks out there, and maybe those that don't know Las Vegas that well, Las Vegas is a really unhealthy city. And if you don't take care of yourself, it's very easy to end up like one of these people. You've really, really got to try to exercise, try to eat right. It's very difficult. Just as a testament to how unhealthy of a city this is, there's actually an entire resort called left ventricular hypertrophy. There is, totally, instead of putting a mint on your pillow at night, they put a beta blocker. It's really interesting. And then, of course, there's a famous Heart Attack Grill, which owns the Guinness record for the most calorific burger, 9,800 calories. And they decided to beat their own record by making an octuple bypass burger. So there's now 8 patties with an optional 43 slices of bacon that you can buy for an extra $7 or $8. And this is some of the things on the menu: chocolate-covered bacon, deep-fried butter. They take a stick of butter, I think, and put it in every milkshake. And the waitresses dress up like nurses. I don't think they're ACLS certified, though. And although they probably should be, there have been at least 2 people I've heard of that have died in the restaurant. And about 2 years ago, somebody developed chest pain in the restaurant while eating. They called 911. Paramedics came in. They wheeled them out. And the other patrons in the restaurant thought that it was all part of an act, and so people were taking photos using their iPhones. No joke, they thought it was all part of a show, and actually this lady ended up probably having a heart attack. So anyway, take good care of yourself. Otherwise, you may end up a victim for this lecture. We're going to talk about ACLS 2013. Now, on the DVD that you have last year's lecture, and this is going to largely represent an update from last year, but just to bring you up to speed, some of the things that we talked about last year, all right? We talked about the fact that if you're working in the emergency department, let's say you've got a 45-year-old guy who shows up in the emergency department with atypical chest pain. He's in the room for 20 minutes. This is the scenario I started with. And then he becomes diaphoretic, clutches his chest, and suddenly goes unresponsive. You look up at the monitor, and you see this on the monitor. He's in ventricular fibrillation. Everything that we've learned from AHA and ACLS and resuscitation literature up through the end of 2011, first couple months of 2012, would have told us that these are the things that we're supposed to do. First of all, the traditional mantra, ABC, has been flipped around, and we're supposed to focus on circulation first and kind of not worry as much about airway, certainly in the first 10 minutes or so with primary cardiac arrest, because people's saturation is probably fine. So avoid positive pressure ventilation. Even the mouth-to-mouth it can be very detrimental because it's increasing intrathoracic pressure, decreases venous return, decreasing cardiac output, coronary perfusion. People don't need airway for about those first 5 or 10 minutes because their central oxygen is already fine. You don't need to worry about the airway. Focus on good compressions. All right, the airway is not a big priority early on. And then you can start bagging them, focus on the airway, maybe after 5-10 minutes or so. And even then, you want to make sure that you're not bagging them too fast. Maximum 8 to 10 times per minute. If you exceed that, you hyperventilate them. That's bad for the brain and also bad for survival. All right, you want to do rapid, firm compressions. And this is a nice statistic to keep in mind, and if you want the reference, just look at the DVD from last year. We talked about that. This is a really important statistic to keep in mind. It's based on the literature that's been published. When somebody has no pulse, for every 10 seconds that they're not getting compressions, for every 10 seconds you take their hands off the chest, the chance of them regaining a pulse drops by 50%. All right? Think about that the next time you're running a code when somebody stops compressions to check for a pulse, to intubate, to deliver a defibrillation, whatever. For every 10 seconds that they take their hands off the chest, you're dropping the chances of return of spontaneous circulation by 50%. Keep that in your mind as a motivation to minimize your hands-off time. And also, we talked about this last year, if you use end-tidal CO2, you actually don't even need to stop to check a pulse. You just keep doing compressions, watch the end-tidal CO2, and at the moment the patient regains spontaneous circulation, their end-tidal CO2 numbers will suddenly jump north. One caveat, though, to be careful of, if you're giving people bicarb for some reason, you're going to get false elevations of the end-tidal CO2. So get end-tidal CO2, use it. All right? Rapid defibrillation. Defibrillation is still the best and probably the most life-saving and most brain-saving thing that we can do for these patients. Single shock, maximum joules, 200 joules on the biphasic, 360 if it's monophasic, and you're going to shock one time. There's not the stack shock, 200, 300, 360. That's out the window. Just start at maximum, stay at maximum when you're dealing with VFib or pulseless VTAC, and get your hands back on that chest and do compressions as quickly as possible. Now, the other thing that we can do to minimize hands-off time is charge the defibrillator while people are doing compressions, okay? So that way, as soon as they take their hands off the chest, as you look at the monitor, if it's VFib, you're already charged. You're ready to shock. Push that button, and then hands right back on the chest. And what they have found is that if you charge during compressions, you'll actually decrease your hands-off time from 15 seconds all the way down to 4 seconds, all right? As opposed to what we used to do, which is you're doing compressions, you stop, you look at the monitor, it looks like VFib. Charge up, charge the defibrillator, and then you deliver the shock, and then hands back on. That takes 15 seconds. So just charge during compressions, and then hands off, this VFib, boom, shock, hands back on. 15 all the way down to 4 seconds. That is life-saving in many cases. Drugs don't work. Studies continue to be published saying that drugs don't work. All right? If you want to use drugs, fine, but just be aware that they don't work. Okay? Amiodarone, lidocaine, vasopressin, high-dose epinephrine, none of those have been found to work. We do it out of habit. And in 2012, I'm not going to take you through this literature, but there's probably about a half dozen studies that were published just in 2012 saying that epinephrine doesn't work. Maybe one or two that said, well, maybe it does, but the bulk of literature is coming out saying even the normal dosing of epinephrine doesn't work. All right? I'm not standing here telling you stop using it, but what I am going to tell you is that if you're using it, don't forget that everything else you ought to be doing is more important than the drugs. All right? Repeatedly, studies are showing the drugs don't actually do anything. Okay, now let's move forward to the 2012 literature. We'll talk briefly about what the focus of all the new literature is during this past year and the first few months of 2013. Everything's focused on post-cardiac arrest care. Right? It's the new wave of literature. People have realized that, you know what, when somebody's in cardiac arrest, there's really not a whole lot we can do. We can do good compressions, we can shock them, we need to avoid hyperventilation, but that's about it. So maybe there's stuff that we can do after their pulses come back that'll save them. And so all of the focus is now, over the past couple of years, is on post-cardiac arrest care. These are only 3 of the probably the best articles that I've seen just focused on post-arrest care. What do you do once you got the pulses back? All right. In fact, the AHA is very on board with this. They published some very nice articles in their main journals. You guys remember the 4 links in the chain of survival. You know, there's early access, CPR, early defibrillation, and then ACLS. Well, the AHA has finally come out and recognized that the P in CPR doesn't work, and also all of ACLS doesn't work. The drugs don't work, the early intubations don't work, ACLS out the window, it's all about BLS. Fortunately, they found a missing link, and they've called that early post-resuscitative care or post-arrest care. So much so, in fact, that a lot of the publications are now just putting 4 links back in there, and notice there's no ACLS link any longer because people know advanced cardiac life support. The drugs and the focus on intubation really is not all that important. The final link there again, post-arrest care. So let's go back to the case we started out with. All right, patient goes into VFib arrest, you shock him, you do good compressions, and now you get them back. Okay, so now you get them back, you've got them intubated, you're bagging or on the ventilator no faster than 8 to 10 times per minute. All right, so what are the post-arrest issues we need to deal with? We're going to get an EKG. What if the EKG shows evidence of a STEMI? They're still unconscious. You just resuscitated a cardiac arrest. They're still unconscious. And you get a 12-lead EKG and it shows STEMI. Or maybe it showed STEMI before they had their cardiac arrest. Well, up until just a couple of years ago, most cardiologists would say, look, they're unconscious. I'm not taking them to the cath lab. But last year we talked about some literature which is saying that post-arrest STEMI, these patients really do need to go to the cath lab. And now the case is settled as far as I'm concerned, because in the national ACC-AHA guidelines, post-arrest STEMI patients go to the cath lab. It's a Class 1 indication. Class 1, in my opinion, that's standard of care. And this is right out of the National Journal for the American Heart Association, the main journal for the American College of Cardiology. All right? The two biggest cardiology journals in the U.S., perhaps even in the world, have said that if your patient has STEMI before or after cardiac arrest, they need to go for a cath lab regardless of their mental status. If you got the pulses back, they go to the cath lab now. That's a Class 1 indication. It's so important, in fact, that pre-hospital recommendations are to bypass the nearest hospital in order to get to a cath facility if they get the pulses back in the field. And so pre-hospital systems around the country are scrambling to change their setups, and there's all this talk about regionalization of post-arrest patients. All right? So now what if you have a non-STEMI? This is still a little bit more controversial, but the controversy's decreasing as well. What if you see ST depressions on that 12-lead EKG? Well, last year I showed you a few articles, and in 2012 there's been yet a few more articles looking at the non-STEMI patients. They're just taking all comers and sending them all to the cath lab, regardless of whether they've got STEMI or not. And what they're finding is that patients, regardless of the 12-lead, after they get resuscitated, even if there's not evidence of a STEMI, their outcomes tend to be much better when they go for cath. In fact, some of the recommendations now are, unless you are pretty sure it's a non-cardiac cause of cardiac arrest, you ought to send them for a cath. All right? So, for example, if they have cardiac arrest from drowning, well, they don't need a cath. If they have cardiac arrest because they're an asthmatic who's slowly crumped and then coded, that's different. COPD, slowly crumping and coding. A drug overdose that codes, you're not going to send them for a cath. But if you don't have an obvious non-cardiac cause for their cardiac arrest, you ought to really be pushing these patients to get up to the cath lab. And there's more and more recommendations that are pushing in that direction. It's not part of the national guidelines yet, but again, there's so much more discussion about that. I think that in the coming years, that will be part of the recommendations in the national guidelines as well. And more cardiologists are taking these patients right up to the cath lab. In our own group, a lot of the younger cardiologists are very liberal about, send any post-arrest patient you get back. I don't care about the EKG. I'm taking them for cath. Some of the older cardiologists are a little bit more reluctant, and they want to know about the mental status. But almost all of them are saying, what's the history? And if the patient has a good cardiac history, they're saying, all right, fine, we're going to take them up to the cath lab, even if the initial 12-lead or the post-arrest 12-lead didn't show evidence of a STEMI. So talk to your cardiologist about that. And again, if you don't have a pretty clear-cut non-cardiac cause for the cardiac arrest, the recommendations are really pushing more and more towards sending that patient for cath. Okay, taking a little mental break here for just a second. We talked about how unhealthy Las Vegas is. Back in 1504, there was a guy named David who was really cut. He was really healthy. He was doing P90X and Insanity, South Beach diet. He was in really good shape. He met an artist named Michelangelo. Michelangelo said, I've got to make a sculpture of you. And most of you know this very famous sculpture of David. What a lot of people don't know is that after the sculpture was made, David went on a vacation to Las Vegas. And he liked it so much, he decided to stick around for about a year. 1 year. Then he went back to Italy, and Michelangelo said, David, you've changed. I need to redo the sculpture. And this is pretty much what it ended up being, all right? So, again, be very careful while you're here in Vegas. Maintain a healthy lifestyle. This is kind of gross. Let's move on. Okay, so now we've got our patient. They're going up to the cath lab. The patient's still unconscious, All right? Is there anything else that we should do? What else do we do? Cool them, that's right. Ice, ice, baby. All right? You got anybody want to sing this for a prize? No? All right, Jeff, you're a child of the 80s. You want to sing? Yeah. All right, so that's right. Therapeutic hypothermia, you've got to cool them. And again, this is addressed in the national ACCHA guidelines. Your post-arrest patient that's going for cath, that's STEMI, class 1 indication in the national cardiology guidelines, they go to the cath lab on ice. Ice locks in the freshness, apparently. Okay? So they need to be cooled and cath. If they're a post-arrest STEMI, that's a class 1 indication. And there have been a lot of articles that have come out in the past year, once again, re-emphasizing therapeutic hypothermia. This is, in 2012, was kind of the 1 year, or rather the 1 decade, the 10-year anniversary of therapeutic hypothermia, and a lot of people have talked quite a bit about advances in hypothermia. There's still a couple of articles that have come out that said, well, maybe it's not as great as we thought, but almost all of the literature is saying that if a patient's initial rhythm was VFib or pulsus VTAC, they need to be cooled, class 1, and if it was a non-shockable rhythm, that's still highly recommended, and that would be a class 2B indication. But I think that recommendation is going to push more towards perhaps even a 2A. These are the original 2 studies that were done back in 2001 that set the whole process in motion. They weren't huge studies, but they were nevertheless important studies, and they showed favorable not only survival, but also favorable neurologic outcome. There are not many things in all of ACLS, in all of resuscitation, that have been shown to take cardiac arrest patients and give them back a decent neurologic outcome. Not even good compressions. The only other thing that's been shown to improve survival and neurologic outcome is defibrillation. You want some numbers needed to treat? Well, the number of patients that you need to cool to save a life is 7. The number needed to treat to improve neurologic outcome is 5. And there's practically no side effects or harm associated with this when the process is done properly. To put in perspective how incredible these NNTs are, the number needed to treat to save a life with defibrillation is 2.5. The number needed to treat to save life with thrombolytics in STEMI, 43. And yet nobody questions thrombolytics. Or how about aspirin in STEMI, 42. And those do have, well, certainly thrombolytics have major side effects we worry about, all right? And for cooling, we're talking about a number needed to treat of 5 to 7. That's an incredible benefit that you can provide your patient if they qualify, all right? So, again, that's why it's been made a class 1 intervention, and for non-shockable rhythms, if the initial rhythm was asystole or PEA and you get them back, then the data is pushing it, is saying it's a class 2B recommendation, but the international, the ILCOR recommendations and the European Resuscitation Council are really recommending this. Most of the American Heart Association recommendations are to do this because the drawbacks are really, really minimal. All right, so the best evidence is still for VFib and pulsus VTAC, but there's a lot of recommendations to do it in other rhythms as well. Now, a couple caveats for peds, it's still being studied. In pregnancy, Haney mentioned a couple of case reports where it was done in pregnancy patients that had cardiac arrest with good outcomes. Those are just case reports. It's still being studied there. Cardiogenic shock, it's being studied with pretty good results. Traumatic arrest, septic cardiac arrest, intracranial bleed cardiac arrest, not really recommended, but people are still studying it. Just a few words about the procedure. I think most people here probably have hypothermia protocols. I hope, and I'm not going to ask you to raise your hand, but if anybody here works in a place that does not have therapeutic hypothermia protocols, you can get hypothermia protocols off the internet. You can email me, I'll send you ours. But you really need to get started and get going with therapeutic hypothermia protocols because internationally it's really, really recommended as, I hesitate to say standard of care because that kind of implies a medical legal definition, but you've got to get on board with therapeutic hypothermia. You can do this very, very inexpensively. If all you do is put ice packs on the groin, neck, and axilla and add cool IV fluids at 4 degrees Celsius, you can cool people at about 1 to 2 degrees per hour. That's pretty darn good. You don't need these fancy endovascular devices or cooling helmets or all these other fancy things that are very expensive. If you have them, fine, but you can start the process even with low-cost type of interventions. And there's studies out there saying that with just ice packs and cool IV fluids, you can actually maintain that hypothermic state for 12 to 24 hours. Hopefully, that's going to be upstairs in the ICU and not still down in your emergency department. All right? Now, this is the first time I've seen this 20% increase in mortality for every 1 hour delay. Right? So sometimes people say, well, do I need to get it started right away? Well, according to a couple of authors, they're saying that they've found some mortality benefit or worsening mortality with delays. I'm sure this is not, randomized multi-center studies upon which this number is based, but again, it really tells us that when you start the cooling process, you need to start it as soon as possible because for every hour delay, it appears that patients' brains are getting worse. So start the cooling process as soon as possible. 20% increased mortality for every 1 hour. Keep those numbers in mind. So what we do is when somebody comes in needing a resuscitation, we try to remember the first bag of IV fluids that gets hung is cool IV fluids. So we'll stock it in the resuscitation bay. It makes a lot of sense to just keep the cool IV fluids in your resuscitation bay, and as soon as that patient arrives, you get the pulses back. In fact, even before the pulses are back, just start the cool IV fluids. There's no harm to that, all right? What about shivering? Well, shivering is going to regenerate heat. You don't want them to shiver, so they need to be sedated. Benzodiazepines are highly recommended. Even paralyze them. Magnesium, that was new to me also, but there's a handful of authors out there that are recommending giving these patients magnesium because it decreases shivering. And in one nice review article in Circulation, the author actually said that they routinely give a 4-gram bolus of IV magnesium, and that significantly decreases the shivering. All right? Now, he didn't say how fast that goes in. You don't want to push 4 grams of IV magnesium unless you're in Torsade, right? But you probably are going to give those few grams over the course of 15, 20 minutes or so. But magnesium, in at least 2 nice articles I've seen, appears to decrease shivering. So benzodiazepines, magnesium, and if necessary, you paralyze them as well. All right? Sometimes people say, well, if we cool them, they're going to get bradycardic. Probably true. Is there harm to that? No. There's no harm to the bradycardia that you may get. If they develop a 3rd-degree heart block or something like that, sure, go ahead and pace them. But for the most part, the literature says that the bradycardia you get is harmless. Sometimes people say, well, if I cool them, they're going to get hypotensive. The studies have said that hypothermia does not cause hypotension. So if your patient gets hypotensive, it wasn't the cooling that did it. It was their underlying physiology. We'll talk more about that in just a second. So don't withhold hypothermia just because their blood pressure is low or because you're worried they're going to drop their temperature. Just start it, and if they get hypotensive, you treat it. We'll talk about that in a second. Some people say, well, they're going to get hypoglycemic. That's true, and when they get warm, the sugar comes back up. You treat hypoglycemia as needed, treat hyperglycemia as needed, nothing special. Same thing with electrolytes. Treat hypo or hyper-K. Usually they tend to get a little hypo-K with the hypothermic process, and then you just treat it. And then when they get rewarmed, they start tending to put out that potassium and get a little hyperkalemia. Just treat them, all right? No big deal, nothing special there. Infection. People say, well, cooling is going to increase the risk of infection. Minimally, negligibly. All right. Now, a lot of post-arrest patients, 2/3 of post-arrest patients will end up developing an infection, usually pulmonary, and that's been related to aspiration during the cardiac arrest resuscitation, not to the hypothermia. So do you need to worry about an infection or immunosuppression from the hypothermia? Again, negligible. I would say the answer is no. Don't worry about infection risk. If you develop an infection, treat it. No prophylactic antibiotics, but if they develop an infection, and 2/3 will, go ahead and treat that. That's probably going to be up in the ICU, though. And then they start getting rewarmed after about 12 to 24 hours. A few other key points from the recent literature about post-cardiac arrest syndrome. Push the MAP to 80 to 100. Now, Haney talks about sepsis. We've been taught that you want the mean arterial pressure with septic patients. You want to push for, 60 or 70 or so. The studies seem to suggest that with post-cardiac arrest patients, you want to be even more aggressive. You want to aim for a mean arterial pressure of at least 80 to 100. in order to maintain good vital organ perfusion. All right? Have a pressor ready to go because almost always these patients will develop hypotension. What happens during the cardiac arrest? Patients get these boluses of epinephrine. So when you get the pulses back, usually the pulses come back and they're bounding and the patient's got a blood pressure of 180 over 100 and you're high-fiving because, we got the patient back, we've got a great blood pressure. And then what happens 15 minutes later? Epinephrine's wearing off, blood pressure starts falling, and then you've got a blood pressure of 60, all right? There's data that says that every episode of hypotension increases mortality. So don't let your patient get hypotensive at all. How do you do that? As soon as you get pulses back, start the norepinephrine drip. All right? Have the norepinephrine drip ready to go, hanging. Started at a very low infusion, and as the blood pressure starts falling, and it will once that epi wears off, as the blood pressure starts falling, you don't have to go mix up your norepi. You've already got it hanging. You just turn the on button, get that blood pressure up. The key thing is don't ever let them get hypotensive. Every episode of hypotension kills. So don't let them get hypotensive. Have the norepinephrine drip hanging right from the start because they will get hypotensive. And again, be aggressive. We're shooting for a mean arterial pressure of 80 to 100. All right? So have it ready to go. Avoid hyperoxia. Last year, I quoted a handful of studies. You can look at the DVD. There's a handful of studies out there that show that hyperoxia is bad for the brain. All right? So you don't need a pulse ox of 100%. Shoot for a pulse ox in the mid-90s. If you have a pulse ox of 99, you know what? Turn the O2 down. All right? Hyperoxia has been shown to be bad for cardiac arrest, for stroke, for MI, and for sepsis. You don't need them to be on a vent with an FiO2 of 100%. Titrate it down aggressively and keep that pulse ox 92 to 94. If your pulse ox is 99, you need to turn your oxygen down because hyperoxia has been shown to be harmful, believe it or not. Right? We all learned oxygen's good, right? In fact, we were all taught that if you put your patient, if you're taking your oral board exam and you don't put them on 100% O2, you're going to fail, right? That's what I learned. Everybody gets on 100% O2. Wrong, all right? What we now know is hyperoxia is dangerous. Shoot for a pulse ox in the low to mid-90s. And also, what else? We've all been taught permissive hypercapnia is okay in most scenarios, but not in cardiac arrest. You want to shoot for a normal PCO2, right? Because if you let the PCO2 rise or fall, it's bad for the brain. Shoot for a normal PCO2. So, in terms of the vent, shoot for a pulse ox in the low 90s, not higher. Shoot for a PCO2 that's normal. Aim for a normal PCO2, not hypercarbia or hypo, all right? So, quick summary of where we are this year. Again, take a look at the DVD from last year to get you up to speed to 2012, but in terms of the 2012 and for the first few months of 2013, here's where we are. Push hard, push fast, and don't stop. Don't let your compressions be interrupted. Shock at maximum joules. Remember, circulation first, and don't worry about the airway for those first 10 minutes or so. New focus is on post-arrest care. What are the specifics of post-arrest care? Number one, if there's evidence of a STEMI before or after cardiac arrest, class 1, they go to the cath lab. And for non-STEMI, you're going to see more and more recommendations to get those patients aggressively cath as well. Class 1 indication for post-arrest care, cool them. If they're VFib or pulseless VTAC as their initial rhythm, that's class 1. They've got to be cooled. And if it's a non-shockable rhythm, it's right now class 2B, but the literature is really pushing in favor of cooling those patients as well. If you're worried about infections, treat it as needed. Worry about dysrhythmias, treat it as needed. Worried about hypo or hyperglycemia, hypo or hyperkalemia, treat them as needed. Don't give prophylactic antibiotics. Don't use prophylactic antiarrhythmics. Don't use prophylactic insulin for hyperglycemia. Just treat them as needed, supportive therapy. And be aggressive about the MAP. Get your norepinephrine hanging before they start dropping their blood pressure. All right? If their blood pressure maintains, fine. Just keep your norepinephrine hanging there with the button pushed off. But as soon as that blood pressure starts falling, you've already got it ready to go. Start that norepi. Don't let them get hypotensive for even a minute because that is actually deadly, and shoot for a high MAP. And for your vent, shoot for a normal PCO2 and shoot for pulse ox not in the upper 90s, but in the low 90s. All right? And with that, there's my email if there's any questions. We're done with ACLS, and I guess now it's time for quickie snappies, right?